Good morning and welcome to today's lesson on surgery and surgical nursing 2. The last time we met, we talked about general pre-operative preparation of a client before surgery. And I made mention that I am taking you through this process because all the conditions that we are going to manage under surgery 2, we are supposed to be doing pre-operative management and post-operative management under every single one of them. But the truth is, it is the same thing that runs through. Any client that is going for any surgical operation will need to go through the 5 components of pre-operative management: psychological management, physiological management, physical management, socio-economic management, and spiritual management. It runs through in all conditions. So once we go through the general management, we are no longer going to be going through like managing under every single condition, manage under every single condition, manage pre-operative management, post-operative management, unless there are certain specifics that differ a little. Other than that, we will not be wasting much time going through the general pre-operative management and post-operative management. So we started talking about pre-operative management, and we have done the 5 components: physiological, psychological, physical, socioeconomic, and then spiritual management. Today we will continue from post-operative management, and after that we'll start to tackle the conditions one after the other. So when a client goes to the theater and returns, whatever care is given to this client after the operation is referred to as post-operative management. Let's see. It is a period of time that begins with the admission of the patient to the intensive care unit and ends after a follow-up evaluation in a clinical setting or home. Before the patient arrives, a post-operative bed is prepared. So one of the first things you will have to do under post-operative management is to prepare a post-operative bed, waiting for the client to return from the theater. So post-operative bed is one of the first post-operative management modalities that is supposed to be put in place before the client arrives. The bed that is prepared must have bed accessories such as bed blocks, sandbags, gallipots, swabs, receivers, mouth gag, artery forceps, and other equipment such as oxygen apparatus, suction machine, anesthetic or emergency tray, and drip stands are all assembled. So all these equipments and apparatuses are assembled by the patient's bedside. That is the post-operative bed that you have prepared for the client. You assemble all these gadgets and equipments around the bed, so that when the client returns and there is a need to utilize any of them, you wouldn't have to start running helter-skelter looking for them because you already have them at the bedside. Okay, so let's see. Once you have your bed in place and you have all your equipment in place, what do we do next? So immediate post-operative care. The patient is received from the theater staff on a trolley or a stretcher with his or her documents from the accompanying nurse. Immediately, the nurse makes a quick assessment to ensure the patient is alive. What we are saying here is, mostly when the client is coming back from the theater, they are lying, or he or she will be lying on a stretcher or a trolley, accompanied by some of the theater staff. So immediately they arrive, the nurse who is receiving must make sure he or she is not receiving a dead body. For all you know, the client died in the process of transition. It is possible. Or even died and they didn't realize it. So if you don't assess, you are likely to receive a dead body. So you need to assess to be sure that the client you are receiving is living. How do you do this? This is done by checking the breathing, by watching the rise and fall of the chest wall, as well as passing a finger under the nostrils to ensure that a dead patient is not being received from the theater team. So what we are saying is, immediately look at the client's chest to see whether he or she is breathing. If the client is alive, you will see the chest rising and falling. If you are not sure, just pass your finger around the nostrils of the client. You will definitely feel it. If the client is breathing, you will feel the air touching or passing on your finger. The patient is then taken, so once you are sure that the client is alive, he is then taken to the ward into an already prepared operation bed. Like I said, you have already prepared your bed. So you now send the client into the bed. Now, positioning. Positioning is one of the most important things because depending on the type of surgery, clients may have to assume different positions. And the type of position that a client assumes will definitely affect the rate at which he or she heals or recovers. If patient arrives unconscious, place him in a recumbent position with the head turned to one side without a pillow. So any client that is unconscious should be put in a recumbent position. I know you know what recumbent position is. And turn the head to one side. The reason of turning the head to one side is to prevent aspiration. We don't want content, that secretion that is coming out of the mouth, to get aspirated. The position is changed to semi-Fowler's position when consciousness is regained. So immediately the client becomes fully conscious, you change the position from a recumbent one to a semi-Fowler's position. The position may also depend on the type of operation performed. Most of the times, the surgeon may specify the type of position you should make the client assume. Tubes from infusions, urine and drainage bags are connected. Now, provision of warmth. Always ensure to keep the patient warm by the use of blankets, if need be, to prevent hypothermia. We don't want the client to go into hypothermia. So as a result of this, we always want to provide warmth by covering the client with enough blankets. Mostly in our part of the world, the weather may not be too cold, so you may need just a simple bed linen, not necessarily a thick blanket. Alternatively, bedside lamps can also be switched on. Ensure patent airway. So what is happening here? A client that returns from the theater, especially unconscious, may not be able to control the secretion that are coming from the GIT or even the respiratory tract. So as a result of these, we need to assist in clearing the airway so that it doesn't become blocked. How do we do this? You suction mucus every 15 minutes or when required till patient regains consciousness with good coughing and then swallowing reflexes. So whilst the client is unconscious, you need to make sure that you suction the client continuously. That is every 15 minutes at least. Or when, we call it PRN, when the need arises. Administer oxygen when necessary. So whilst you are doing this, you are checking your vital signs. If SpO2 is not good, like that is if it is below normal, then you will have to administer oxygen as needed. Observation. Firstly, you need to observe the level of consciousness of the patient. Check the airway by ensuring that the tongue has not fallen back. Very important. So whilst you receive the client into the bed, these are the things you need to assess. Check for circulation by feeling the radial pulse. Be sure that the circulation or the pulse is within the normal range and then is bouncy enough. It's not faint. Check the operated side for intactness of dressing. If there is bleeding, do not remove the plaster, but reinforce with more sterile gauze. Plaster and inform the nurse in charge. You know, what happens is, it is possible that the client may still be bleeding from the site of operation. And at times, if some of the vessels are not well ligated, they could continue to bleed until they lose a lot of blood to the extent that they even become anemic and they could die. So what we're saying is, you need to make sure that you check the dressing to see whether it is dry or soaked with blood. If it is dry and intact, that is fine. But if it is soaked with blood, don't open immediately, but reinforce with more gauze and plaster, and then you inform the nurse in charge. Observe the type of infusion a patient may be on from the theater, the quantity, the flow rate, and then you record on input and output chart. So what we're saying is, you need to make sure as part of your observation, assess or check for the type of IV fluids, intravenous fluids, that were brought from the theater. Check the flow rate that has been recommended by the surgeon, and make sure you do your calculation to give the right dosing. Check the cannula site to rule out swelling, pain, and dislodgement of needle. So at the site where the cannula is, observe there as well as part of your observation. Make sure the cannula is intact. Make sure it is not tissued. Make sure the fluid is running smoothly without blockade or leaking. Check catheter in situ for continuous drainage, color of urine, amount drained, and record. Glance through operation notes for any specified position and instructions. Document all findings and report abnormalities. So all that are the observations you are supposed to be making. And like I told you earlier on, I keep repeating, we are doing this because it is something that is common in all the observations that you make are the same thing in all conditions, in all surgical operations, unless certain basic specifics depending on the type of condition that may differ a little. Vital signs. Check vital signs every 15 minutes for the first 1 hour, then have an hour in the next hour, and then continue, and if the condition is stable and good, half hourly for the next 2 hours, followed by 4 hourly checks and document. So that is how the vital signs are supposed to be checked. All right. Let's see. The client that is unconscious from the theater and you are managing on the ward can regain consciousness at any point in time where your attention may not be with him. He may struggle during that period of time and could even fall off from the bed. So we always want to put modalities or measures in place to prevent injuries from happening. So what do? Nurse patient on a bed with covered side rails or on low bed. So what we're saying is, raise the side rails of the bed and then make sure you part them, you cover them, especially metallic beds, so that when the client gains consciousness and abruptly struggles or something, he or she may not fall out of the bed because the bed rails have been risen. And also if he hits the arm or the leg or something against the bed rails, because they've been padded or covered, he or she will not sustain any injuries. Medications. Assist to administer all medications such as analgesia, antibiotics, injections as ordered and record. Nail pause. Ensure patient takes nothing by mouth in major abdominal surgeries until bowel sounds return. So whenever a client returns from the theater, unconscious, or even when he regains consciousness, we still maintain NPO. NPO is nail pause. You don't give anything by mouth until the client's bowel sounds have returned. Similarly, you supervise patient to take in prescribed fluids if or as ordered. Now, personal hygiene. Bed bath and groom patient morning and evening. And then you can assist the client to do this when he or she regains consciousness and is able to do so. Give assisted mouth care twice daily. Subsequent postoperative care. Splinting of operated site. You know, we talked about coughing exercise, which we treated in the preoperative management, which we said you have to teach the client how to splint the site of the incision before he or she coughs. The coughing is supposed to aerate and clear the lungs to improve oxygenation and healing. But when he or she coughs without splinting the site, the pressure that is created within the abdominal cavity can cause gaping of the wound. So as a result of this, the lesson that you taught him during the preoperative management will now be implemented. He needs to splint the site before he or she does coughing exercises. Remind patient to splint operated site before and during coughing post-operatively. Early ambulation. The goal of early ambulation is to improve post-operation circulation, prevent venous stasis, and promote optimal respiratory function. You know, I mentioned something called deep vein thrombosis, which I say you should teach the client leg exercises during the preoperative management, so that when the client comes back, he or she will be able to do these preoperative exercises, postoperative exercises, leg exercises. This is supposed to improve circulation and then to prevent blood from clotting and depositing within the veins and can cause fatality to the patient. Teach the patient to frequently turn in bed from side to side. Teach patient how to get out of bed, that is, turn to one side, push self up with one hand and use the swing and then swing the legs out of bed. Encourage the patient to get out of bed, walk around the ward and then to the entrance and out of the ward if he or she is able. Encourage him to do that. This is all referred to as early ambulation. And early ambulation improves circulation and then improves healing of the patient. Nutrition postoperatively. Nail per os, like I said, till bowel sounds are present. Intravenous fluids are given during the period of nail per os. Then sips of plain tea or water as prescribed by the surgeon. So before bowel sounds resume, it is only intravenous nutrition or intravenous fluids that are given. But once bowel sounds resumes, then you have to give sips of plain tea. Sometimes it is prescribed that there shouldn't be sugar or even milk in it, just plain Lipton or tea, Milo. And in some situations too, it could be water. It takes sips of water. Then from there, you move on to fluid diets, such as light soup. And then from there, you move on to light diets, such as kafa, what we call agidi, and light soup, and then soft banku, etc. Then from there, you now move on to normal diets. So from plain tea to fluid diets to light diets and then to normal diets. Now, wound care. Any client that is subjected to operation definitely comes back with a wound. You call it incisional wound. So you don't have to leave the wound uncared for. You have to take care of it. What do? The wound must be dressed according to the surgeon's instruction under aseptic techniques. Dressing on the operated side may be changed on the third day postoperatively according to the surgeon's instruction. When dressing the wound, observe the nature of the stitches and their intactness. You also observe for any swelling at the site. You observe for discoloration. You observe for pus and then bad odor, which may all be indicating infection of the incisional wound. Document and report any abnormal changes at the site. Elimination postoperatively. The nurse must encourage regular emptying of the bladder and bowel. The patient must pass urine within hours of operation. Otherwise, nursing measures should be employed, including passing of catheter in order to empty the bladder. If no bowel action in 3 to 4 days after operation, you give appearance or stool softness. Sometimes suppositories or enemas may even be given in order to induce passage of stool or soften stool for passing. Higher fiber diets must be served and encouraged. So you need to give high fiber diets. You know what that does. It bulkens the stools, attract water into it, soften it so that the client can smoothly pass them out. Deep breathing and leg exercises. You know, this was one of the topics we did under physical care, physical preparation in the post-operative management, pre-operative management. So, with the deep breathing and leg exercises, while in bed, deep breathing and leg exercises must be encouraged. Ambulation can commence 1 to 3 days depending on the type of condition. Removal of stitches. Some stitches are absorbable and others are non-absorbable. The former is tissue friendly, hence absorbed by the body tissues. The latter, which is the non-absorbable tissues, has to be removed according to the surgeon's instruction. Basically put, what I'm trying to say is that with the absorbable stitches, you don't remove them. The body will absorb, the body tissues will absorb them. But those that are the non-absorbable, they have to be removed after a number of days when the wound is healed. Some stitches are removed on alternate days, which are 5th to 6th day, and the remaining on the 7th to 10th day. Others are taken out all at once on the 10th day. You document interventions at every stage. Rehabilitation. Rehabilitation is the process of assessing the client to adjust back into society, regaining his or her strength and improving on the affected part. So let's give an example like a client who went in for an amputation of, say, the leg. This client comes back and then walking becomes a problem. You need to rehabilitate him. Maybe by using clutches, teach him how to use clutches so that he or she will be able to ambulate effectively. This is a form of rehabilitation. This care may include the use of prosthesis depending on the type of surgery. Another example is breast amputation. If you have a breast amputation done for you, we could put artificial prosthesis or breast there in order to make you look normal. Health education. The importance of health education is to ensure that patient has adequate understanding and information concerning his condition before discharge so as to gain maximum recovery. The patient is educated on the following. You teach the patient on the medication, the doses, and then the duration. So, the client needs to know the drugs he or she is taking. What are the dosing regimen? And then how long is she supposed to be taking these drugs? If you don't do that, he or she goes home, the pain resolves, and he leaves the drugs. He won't take them again, and then comes back, and the plate gets infected. Moderation in physical activities. So you educate him on how to do physical activities moderately from the beginning until when he or she is fit enough to resume normal activities. The nutrition. You have to educate the client on the type of nutrition that is good enough or is well balanced in order to improve healing. Rest and sleep. You need to educate the client on the need to have enough rest and then to sleep well, because these are the measures that will help boosting his or her immunity in order to improve his recovery. Potential complications and how to prevent them. So you need to educate the client on complications that may occur or that are potential to the surgery that has been performed. And they teach the client on what to do when any of these complications ensue. Allow patient and relatives to ask questions for clarification and give them appropriate answers before they are discharged home. That is very important. You need to give them the opportunity. Let them ask any question that baffles them or that they do not understand, and make sure you give them the right answers. If you do not have the right answers, you direct them to the right quarters or the right personnel who have the right information to provide them. So, this brings us to the end of post-operative management. And like I said, it runs through. Almost all that we have done will be done for any client with any type of surgical intervention. So when we start to talk about the individual surgical conditions, we are not going to be doing pre-operative management, post-operative management, pre-operative management, post-operative management, and all of them, unless certain specifics that differs little by little. Those are the ones we mention.